Well, good morning, everybody, and a very warm welcome to this webinar on resetting the NHS. As it's been said, I'm Neil Dixon, former Chief Exec of the Confederation, on this, my last outing for the Confed. The webinar coincides with a report the Confederation is launching today, which you may have seen on the media, which brings together the many strands of the NHS Reset campaign. I want to pay tribute right from the outset to the hundreds of members and partners who've contributed and are contributing to this work, which we hope will help reshape our health and care system now and as we move forward, and in time, we hope, emerge from this terrible period. Our aim for the webinar, though, is to make this session as interactive as possible and to put your thoughts and questions to a prestigious panel, which will be introduced in a moment and mediated by our chair, Lord Adebowale. After I've reflected on the NHS Reset campaign and the report, Victor will invite you to take part in an online poll and then discuss with the panel their experiences during the pandemic before putting some of your questions to them, both ones that have been submitted before and during the webinar itself. And before we finish, there'll be another online poll with Victor closing the webinar at 12 o'clock. Now, the idea of NHS Reset arose from the universal and consistent message from our members during what I suppose we must now call the first surge. Their view from early on was that the ambition should not be for the NHS to recover, in the sense that recover means going back to what was there before. Instead, they wanted to capture the host of positive changes that had been delivered. It needed to be a process of reshaping the service and establishing a new normal. What went on then, and is continuing, was an extraordinary set of changes, and I don't think many of us could have predicted what was going to happen. It was easy now, and it is easy now, I think, to forget the siren voices who said the NHS would not cope, that it wasn't in a fit state to manage what was then a largely unknown virus. It was difficult to refute the charge that, given our small ICU capacity, the fact that the service was already under huge pressure, how would it manage? And at the Confed, what we said publicly and privately was, listen, our health service has shown that in a crisis, it can flex. And although it'll always be impossible to say that any service can withstand any level of demand, we said the NHS will adapt to meet this new national threat. And of course, that is exactly what happened. The service was turned inside out to provide the best possible care for nearly 20,000 hospital patients with COVID, and then more than that in the community, the bit that's often forgotten, I'm afraid. Many will have had a wry smile when they saw the headlines in late January. I do remember this, how China is building a coronavirus hospital in a week. And it was a wry smile because, of course, we could never do that, could we? Well, we did. The amazing achievement of constructing the Nightingales in England, the Dragon's Heart in Wales, was perhaps the most obvious evidence of action. Of course, in every hospital, in every community service, throughout primary and social care, the world was being turned upside down. And all the while, and it is worth remembering, this is something Simon Stevens talks about quite a bit, while we were doing that, millions were still being treated, a fact that tends to be forgotten. Even at the height of the virus, for every one COVID patient being treated, 2 non-COVID patients were being treated. Incidentally, the figure a couple of weeks ago was 1 COVID patient, 166 other patients, which shows how much has been done just in recent times. But of course, the creation of a COVID service did mean the suspension or scaling down of routine screening, diagnostic surgery, and other treatments, and very different interactions with patients than they were used to. No one in our world, I think, has any illusions about the collateral damage this has caused, nor indeed the impact of lockdown and other restrictions on physical and mental health, and especially to the most vulnerable in individuals, families, communities. But alongside this trauma and adversity came this surprising development, how so many services were transformed. And as today's report shows, sometimes in ways previously unimagined. I can't say how many times I heard chief executives say to me at the height of the pandemic, earlier this year, that what would have taken years has now been delivered in weeks. And clearly, one of the many challenges you face now has to be to make sure these positive moves are sustained. It strikes me that there are at least 4 types of change. First is the rapid adoption of digital technology to deliver existing services. Where there had been reticence and concern about using virtual connectivity, there was a willingness to embrace and often surprise at what could be achieved. Then there was the rapid introduction of services, some completely new, others such as mental health triage for A&E or discharge to assess, which had been going on in some places, but were now being adopted much more widely. Thirdly, there was a willingness across the board to take on new roles and to work in new ways. Given authority and freedom to act, I think the staff of the NHS, especially clinical staff, solved previously intractable problems. And fourth, and probably least visible, we've seen new and deeper relationships, again, all over the service, but also crucially between leaders within the NHS and between them and our partners in social care and local government in the third sector, and with suppliers and with industry. As today's report makes clear, the road ahead will be difficult. We entered the pandemic under significant pressure, with demand outstripping the ability of the service to meet key performance targets. Now there are local outbreaks and what looks like the coming second surge, a huge backlog of treatment as well, and the need to restore services while operating with infection control measures that significantly reduce capacity and productivity again throughout the service. And with at least some staff who are physically and emotionally exhausted. So I don't think anyone's under any illusions about the challenges. What there is, though, is a determination to hold on to and build on the changes which the crisis has enabled, and a determination, as far as possible, to retain the conditions which enabled those changes to flourish. Today's report identifies 5 factors that will be required if this ambition is to be realised. The first is honesty and realism. It points out that the support and understanding of the public has been critical to enabling the NHS to respond effectively, and that the public rightly expects routine services to resume as quickly as possible. Already, fantastic strides have been made. Emergency admissions now back to near normal levels. Routine operations earlier this month were 250% up on the level at the height of the pandemic. Diagnostic activity up 150% since April. But the pandemic's impact on capacity is likely to go on for several years. The service needs government investment to support new ways of working that will enable it to safely restore services, as well as the understanding of the public while the service adjusts and deals with this big backlog of patients needing care. So again, here is a plea to political leaders to help manage public expectations about what is possible. There is amazing support for the NHS. It was Nigel Lawson's, Mrs. Thatcher's Chancellor, once said the NHS was the nearest thing the British, I think he said the English actually, but he meant the British, had to a national religion, and he was right. But as we embark on the next phase in these unprecedented times, it's also reasonable to ask for a reassessment of what the NHS can realistically be expected to deliver. Secondly, and allied to that, what capacity and resource does the NHS need to meet the challenges ahead? In 2018, the NHS received across the UK a 5-year funding settlement worth £20.5 billion. This was to have been reassessed in a comprehensive spending review in November. Now, with borrowing in the state and the economy in the state that it is, the budget's been scrapped this year. I think it now looks pretty certain that the best will probably get this time as a 1-year settlement. But it is clear that additional revenue and capital will be needed to cover the additional costs of rising demand, while also enabling the NHS to play catch up with the backlog of treatment. The expected surge in demand for mental health, for example, is likely to be up 20%. That will obviously require additional resources too. I know the Confed sometimes sounds like a gramophone record on this, but the NHS will not be able to respond effectively without a sustainable social care system, which frankly we're still waiting for, and it also needs that long-term funding settlement. It is of course reasonable for taxpayers in return and the Treasury to expect the NHS to drive through transformation set out in the long-term plan in return for this. And there is certainly a commitment among leaders at local level to continue to innovate and deliver services in new ways. And the pace of that looks set to increase. Third, one of the reasons why so much was achieved was the lighter regulatory burden, which has changed behaviours at local and national level. This must be sustained. We need to strip away unnecessary bureaucracy, reporting and regulation that for too long has just failed to enable leaders to innovate and to create new things and do things in the way that they want to do it. Fourth, we need to sort out the architecture of the NHS in England with minimum fuss and disruption, yet creating something that reflects our ambition for integrated services. I think if COVID has shown us anything, it is how interdependent all our services are. So there's now widespread acceptance, I think, that the 2012 Act has left a confused architecture that wastes time, effort and money. So we need a new legislative framework which brings some simplicity and clarity for that, and a common purpose for local leaders. And last but by no means least, the pandemic has shown how important it is for the health and care system to play their parts, systems to play their parts in tackling health inequalities. It's obvious the NHS can't do this on its own, and some humility about what can be achieved will be required. But healthcare services can make a difference, and NHS organisations in themselves as employers, as local resource, can make a difference. It will require sustained and funded action at national and at local level. As today's report says, there does appear to be a commitment to do this, but it will require a radical and conscious shift in every health economy, and particularly towards a strategy that is based on population health. I'm sure some of the panel will reflect on that. So plenty to reflect and chew on. I hope some of this resonates with you and that you will get the chance to read the report in full and share it with your teams. For NHS Reset, to quote Winston Churchill, this is not the end, not even the beginning of the end, but perhaps the end of the beginning. And I think there's enormous scope for the enthusiasm which the campaign itself has engendered to keep being a focus of the service, and in a way that will help us change the NHS through what is undoubtedly going to be a very difficult period going forward. I now want to hand over to Victor to lead us through the rest of the webinar. Victor, if you'd like to switch on your microphone and camera and join us for the next stage. Thank you.
Very much, Neil. Hello, everybody. I'm going to do two things. First of all, introduce you to our excellent panel, and then I'm going to ask you a question, which you will get the answers to because it's an interactive session, and there will be a poll, a question for which there will be a poll about the situation that you're all facing. So without further ado, let me introduce our first panel member. She is Dr. Farzana Hussain. Farzana has been a GP partner for 19 years in East London, clinical director for Newham Central One Primary Care Network, and looking after 66,000 people. And she's also the co-chair of the PCN network. Welcome, Farzana. Then we have Paul Burstow. Paul is the independent chair at Hertfordshire and West Essex Sustainable Transformation Partnership, STP, and chair of the independent charity, the Social Care Institute for Excellence. Paul is also a part-time professor of mental health policy at the University of Birmingham School of Social Policy, ignore my dog. For 18 years, Paul represented the constituency of Sutton and Cheam as a Liberal Democrat. He was appointed Minister of State for Care Service in 2010, and during which time was responsible for developing the government's mental health strategy, No Health Without Mental Health, and for drafting the care provisions of the Care Act. Next, we have Julia Ross. As well as being the Chief Executive for Bristol, North Somerset and South Gloucestershire Clinical Commissioning Group, Julia is the co-executive lead for the Bristol, North Somerset and South Gloucestershire Sustainability and Transformation Partnership, STP, Healthier Together. We're going to have to shorten some of these names. The STP is a collaboration of 10 health and local authority partners across Bristol, North Somerset and South Gloucestershire, delivering services for a population of 1 million people. With an NHS career spanning 30 years, Julia has successfully led organisations through large-scale complex change, service reconfigurations, and has worked in both commissioning, service provision at national, regional and local levels. Welcome, Julia. And last but not least, we have Donna Hall. Donna is the chair of the New Local Government Network and chair of Bolton NHS Foundation Trust. Donna is also a non-executive advisor to Birmingham City Council and also an integrated care system advisor to NHS England. Donna was CEO of Wigan Council for 8 years and developed the Wigan Deal, a new relationship with residents which delivered 160 million savings and improved services and resident satisfaction. She was also accountable officer for the CCG. So before I come to the panel, I want to ask you all good people on this webinar a question which you will answer immediately, and we'll see when the poll comes up. So the question is this: how confident are you that your organisation, practice or sector will be able to manage winter pressures on top of a second wave? And the poll should be up on your screens now, and you are asked to select one of the following: not at all, partially, cautiously positive, or very. I'm assuming that's very positive. So as you can see, there is a response, 6% not at all, partially 51%, cautiously positive, and very 5%. I think that says something about the resilience of NHS and social care leadership, which no doubt my panelists will pick up. I'm going to ask our panelists in the order I've introduced them, so starting with Dr. Hussain, just to open up, really, to reflect on your experience during the pandemic. Just what's happened to you, yours, your practice and your communities during this horrific period? Dr.
Thank you.
Hussain.
Thank you, Victor, and it's a delight to be here. Gosh, it's been a whirlwind, hasn't it, I think, for primary care. So I work as a GP in Newham in East London, which is obviously sadly known for having the highest COVID death rates in the country. And I have a list of 5,000 patients. And as you said, Victor, I'm also clinical director for one of our 10 primary care networks, and we look after 66,000 of our residents. So I was really pleased to become chair of our National Primary Care Network at Confed, because I really believed before COVID that primary care networks were a really good thing. It was a really great thing to give my patients joined up care. Obviously, COVID coming has been such a tragedy, but some of the really good things, every clouds have silver linings, have been that, as Neil alluded to earlier, I think it has accelerated some of the aspirations that I think a good primary care network would have wanted to have, the aspiration in the long-term plan about the PCNs being those building blocks of ICS. So primary care, as usual, in general practice, because we're small and agile, we were able to really look at our systems and change them quickly. So in my practice at the Project Surgery, we implemented total online triage in only 3 days. We'd been faffing around for the year previously, having the technology, thinking we'll do it, we might do it, we might not do it. And then COVID hit. And the first thing I thought of is actually, how are our patients going to get that access to us, particularly when they're afraid to come out? A lot of people thought that general practice was closed because we weren't seeing people at the first point of contact face to face, and having that online facility meant that most of our patients were able to actually access us 24 hours a day. And for those that couldn't, that have digital literacy or digital poverty issues, I am working in an area in Newham where we have high levels of poverty. English is a second language for most of our residents. So to think about how we could free up the phone lines for them and think about making alternatives. I think working with the PCN, Victor's been fantastic. So we not only have 73% BAME population in Newham, 80% of my staff are also BAME. And sadly, we had somebody I know very well was the 5th GP to sadly pass away in the country, and that was one of my colleagues in Newham. So the ability to remote work digitally, I think, really helped our workforce as a primary care network, particularly with those added roles, the additional roles that now there's more coming in to primary care networks, and we already had link workers. And as for me as a GP, as a clinician, it was fantastic to see that non-medical role and how much our link workers did with our shielded patients, and also the tier just below, those people that needed extra help. Lockdown has been incredibly difficult mentally for so many of us, and seeing those link workers really manage to work with us in the PCNs was helpful. Getting that joined up, working with social care. We know that care homes had huge tragedies, and perhaps we didn't act on that as early as we could have done, but seeing those primary care networks really maintain enhanced care in those care homes. And then of course the testing came out. And I think looking forward now as we cautiously approach this possible second wave, and I'm really encouraged to see the poll that most of us haven't given up yet, and you know, that's a credit to our NHS and all the people that work in the NHS. I think looking forward now, there are certain things that we would continue to take forward, such as the digital ability, and to be able to have our workforce have that flexibility of working remotely, and to be able to widen our PCNs with the extra roles coming in, so that we are offering our communities full health, not just in the medical model, but full health, and working with our ICSs, and of course our secondary care locally have been fantastic, jumping on for joint clinics, because they're doing things on video, we're doing things on video, a joint way of working that we just never would have had without COVID. So while it's a tragedy, I think it's given us some real opportunities, and I'm looking forward to this new way of working and embedding it. Thank you.
Thank you very much, Dr. Hussain. Can I turn to Paul Burstow now for your thoughts on how COVID has affected you, yours, and your system?
Thank you, Victor. And I think probably the first thing I was going to say was that, in a way, my personal experience is a sense of both deep disconnection and at the same time greater connection than ever before. You know, from the comfort of a bedroom, one can chair a meeting and run all sorts of conversations and be closer to people in one way, but at the same time struggle to build the new relationships with people that are joining your team virtually. And I think there is a real sort of dichotomy there, I think, about our experiences. And I think I would also just say my own experience is one of great privilege, the fact that I am able to do this work in this way, and a great acknowledgement that there are many people who can't do that and have had to face much greater levels of risk, both within the NHS, in social care and elsewhere, than I personally have, and indeed many of us who are in leadership positions. I think for Hertfordshire and West Essex, the sort of things that I would just highlight are ones that would echo what we've just heard and what we heard from Neil just now. I think first is the power of relationships within the NHS and with local government and the wider community and voluntary sectors. The fact that where those relationships were at their strongest, and they were very strong in Hertfordshire and West Essex, it meant that mutual aid flowed easily, and as a result of that, more support was provided, particularly into care homes, than might otherwise have occurred. So I think that power of relationships is really key. The ingenuity and innovation in the face of adversity that I think we have seen, that sort of re-engineering of services to pivot towards being COVID secure and responding to the first wave of COVID. And the rallying round of community. Not just that effort on the doorsteps of people clapping, but the actual tangible, practical support. People volunteering in huge numbers, perhaps huger than we were then able to fully embrace at the start, of the pandemic. I just have one example in Watford General Hospital, right next to Watford FC. The football club was absolutely, and still is, absolutely amazing in terms of opening its kitchens and providing all sorts of other practical support. So that sort of engagement by community in all its forms was incredibly powerful. Perhaps a lesson that we in the NHS need to draw on in terms of how we move out of the pandemic to a more, if you like, asset-based ways of working. And then I think the final thing in terms of the Hertfordshire and West Essex experience is the fact that we've seen a huge acceleration in trends that were there before in terms of the adoption of digital channels and remote working, and I think those are incredibly important. But I think there are a couple of things I just wanted to flag as frustrations, if I may. One is what I think is the sort of cascade of compounding risks that the pandemic has triggered. We're seeing the depths of the recession that we are now in, and I think there has been an absence of national leadership when it comes to the provision of a coherent strategy to mitigate and respond to the psychosocial harms that have already occurred and will continue to occur as the pandemic continues to unfold. And I think we need more national leadership from government on those psychosocial harms. We've seen it internationally, New Zealand particularly to the fore in that regard. Social care, if we didn't know beforehand just how fragile and vulnerable our social care system is, we've seen that very powerfully during the pandemic, graphically demonstrated. And my final point, Victor, is really just to reflect on a meeting I attended as chair of the Tavistock and Portman NHS Trust in London, called in the wake of the murder in the United States of Mr. Floyd and the Black Lives Matter movement. And I have never been in a meeting with NHS staff where staff were so angry and feeling let down and struggling to work out who they felt let down by in terms of their experience of everyday casual racism and the challenges that Black Lives Matter were raising, and the fact that they didn't feel there had been a strong enough response to those issues, not just at the moment they occur, but in the months and years before. And the very final point, Victor, is maybe a trite comment, but in a way, the climbing of a mountain in response to COVID has been the easy thing to do. I think we're now beginning to learn just how hard it actually is to climb back down that mountain. And that's where people start to fall. And that's where, with people so tired, we now need to focus our support on supporting our staff even more than ever.
Thank you very much. That was great. Thank you, Paul. Julia, your thoughts on the impact of COVID on you and yours and your system?
Thanks, Victor. I had a very interesting personal experience because I happened to be on holiday in Australia when everything hit and had to go through that real anxiety of our flights being cancelled and needing to find ourselves back here. And when I landed back in the UK, my whole organisation had been turned upside down in response to the pandemic. So it was a very interesting personal experience. And then on top of that, I'm in the clinically extremely vulnerable group, so also experienced myself the challenges of shielding at home, which I have to say was really impactful on my emotional well-being and mental health, really. So, and I'm in a very privileged position, but it does mean I have some sense of what it must be like for people who don't live, you know, in the Mendip Hills, where I can get outside and enjoy the things around me. So I really am and have been conscious of that. Turning to the NHS, though, I'm enormously proud of the way we responded to the pandemic. Of course, the NHS is always great in a crisis, and I think we have proved again how great we can be in a crisis. I think that the Confed research has really captured much of it, but I suppose what I'd pick out is that well, really, I suppose I'd summarise it in the unprecedented pace and scale of innovation that we've managed to put in place in response to, you know, a really clear task, a shared sense of purpose, a shared idea of what had to happen. And I think those things have been great. That's meant we saw just a massive step change in our alignment across the system, the clarity we had about what needed doing, and seeing people really take personal responsibility for doing it. So one of the fascinating bits of feedback I think we all are hearing, and in fact Neil mentioned it in his introduction, is people saying to us that they feel like they've been empowered and that bureaucracy has been reduced. And as a system leader, I've sort of scratched my head about that. I've thought, well, it may depend on where you're sitting in the system, of course, because it hasn't always felt empowering. There's been quite a lot of top-down direction, as you would expect in a level 4 critical incident. But I have to say, people somehow have found a way of taking up personal responsibility for getting stuff done. And that's meant we've been able to do the sort of things that Fazana's been talking about in primary care. It means we've been able to do the sort of things across primary and secondary care in terms of really transforming outpatients, which is something we've been, wanting to do forever. It means we've been able to work in a wholly unprecedented way across health and social care in terms of supporting the care sector. I agree, we came to that late, but my goodness, we really managed to come together in a way, I guess, we've all wanted to do really for a very long time. And some of the things that have enabled that, of course, we can't help noticing, can we, that money's been no object. And I think that that has enabled a different type of conversation, a different type of thinking about priorities and so on. But of course, we've made some great strides, but it has come, I think, at a price, and that's something that we're now having to turn our faces to, is the price it's come at. And we talk about health inequalities, of course. We talk about the BAME community, and there are many others as well. Last night I was with parent carers of children with complex needs in one part of my patch. And if this was a group that didn't get great services before the pandemic, they've really suffered through the pandemic. And we've got to turn our attention back to some of those groups that historically have been underfunded. And I have to say, I'm concerned about that in the context of the extreme focus on the restoration of acute services. I think we need to turn our attention to the range of ways in which people have been impacted. So certainly in terms of waiting lists and 52-week waits, something we all want to improve. But listening to those parents last night made me think, my goodness, we don't half need to balance our approach. We've done some really detailed work on a mental health business case locally, and I have to say we're clear in our modelling that we're expecting the additional demand to be up 30%, not 20%, and we're already beginning to see that come to pass. And of course, we're working hard to think about how we invest in services that will support people with mental health needs. And then, of course, there's the whole new vulnerable group. We talk about people who have lost their jobs, perhaps people who would never have dreamt in a million years of being without work. We talk about people who've been socially isolated, my neighbours who are elderly. They were elderly before, they're still elderly, but their mobility has been really reduced as their world has got smaller and smaller, and now they struggle with fear of going out, they struggle with physical issues, etc. And we need to pay attention to those people. And one group that I'm really thoughtful about, Fazana, you talk about those who are digitally excluded, and that's absolutely right, but we found a group who are digitally excluded and also fear face-to-face services because of the risk of infection. So there's a whole cohort of people that we may not be able to get close to at all. So one of the real benefits of COVID has been, of responding to the pandemic, has been the way that we have worked so much more closely with community organisations, with the voluntary sector, with volunteers, etc. And we need to build on that now in order that we can really support those people who most need our help. And as I said, I do have a concern about, by so focusing on recovery in acute services, we mustn't neglect those people who are actually most vulnerable in our society. And just one final word for me, Victor, is I can't help thinking that all that additional financial investment that's come into the NHS alongside the massive recession that Paul's mentioned, I can't help feeling there's going to have to be a payback at some point, and how we go about that is going to be just so important. So it brings me back to the key point I think that Neil and others have made, is we have to be open and honest with our communities. We have to continue to engage our communities and bring them on side, as we have to make some, I think, really difficult decisions going forward to ensure that we get the balance right of where we can provide the best help to the most people, where we can get real value out of the things that we do, and where we can ensure that those people who are most vulnerable in our community don't get worse. That's it for me. Thanks.
Thank you very much, Julia. Donna.
Hi, Victor. Thanks for inviting me to this panel, and hi, everyone. I'm not going to repeat what other people have said. That's the trouble with going last, isn't it? Everyone's nicked your ideas. Yeah, thanks. The report's brilliant. I had a chance to read it, and it really is. I think there's never been a more important time to reset, not just to recover, but to completely rethink the whole role of the NHS within place. I don't think it's actually just the NHS that needs resetting though as well. I think it's local government. I think it's the way we engage with police, with the Department of Work and Pensions in a place. It's the entire gamut of public services working differently, as Julia's just said, with local communities, and really almost brokering a new social contract with citizens for the future, which is what we tried to do and still going on in Wigan as part of the Wigan deal. It was, we're not here to fix you and do things to you. We're here to enable you to be the best that you can be, which is, I think, what we need to think about the whole future role of the NHS within our local community. So well done with the report. I think it's a great piece of research. And I think I agree with much of what's been said. We've seen both the best and the worst of systems, our systems working together. The best, our frontline staff have been amazing. You know, we've lost hard-working frontline staff. We've sadly lost their lives through COVID. We've seen leaders work together with a different culture, actually governing the way that they work together, and the ego's kind of gone out the window. We've got, you know, a different culture that's developed overnight, really, which is brilliant. But for me, the most kind of symbolic thing has been communities and mutual aid, as Paul said earlier on in his intro. I think, you know, they've outstripped any public service, the way that they've worked together to support communities and get to places that we just can't get to as quickly as we needed to do. Just on the worst, I think, you know, we've seen through some of the gaps, as Paul said, in national strategy around test and trace, the centralising nature of some of that stuff that should have been. We should have looked at what we had in place in local NHS systems and within local public health systems within local government as well, and built upwards rather than trying to do it top down. That has caused delays and has been problematic, as I won't repeat what we know about what's not worked. So for me, I'm going to wrap up because I know we're running out of time. For me, I think the reset's got to focus on place. It's got to focus on population health and on communities. We've seen the power of that. We've seen that really come to the fore in the last 6 months, and building up from that, rather than having integrated care systems, let's try to build integrated community systems that put prevention at the heart, that put community and voluntary sector activity at the heart, and let's try to fund the social infrastructure as well as the health and care infrastructure. I'll leave it there. Thanks.
Thank you very much, Donna. There's some questions that I want to ask you, if you don't mind, panel. And the first ones are about sort of the immediate challenge. And we've seen the phase 3 letter, you know, the phase 3 constitutional standards and long-term plan. And I'm curious about what you think are the challenges in aiming to deliver phase 3 and adapt and adopt how we switch services back on and progress the long-term plan, which is still in play. You know, it's still an important and its modernisation agenda. And in the context of what Donna's just said, it's quite an important question, because the immediate isn't going to go away. So I'm curious about your reflections on that, and perhaps I might start with you, Julia, reflections on that, and then seek views from each of you as you see fit on that question. So, you know, how are we going to meet the challenges in the phase 3 delivery challenge? You know, what are your thoughts? What are your thoughts about that? while keeping the adaptation switch on?
So I think I referred to some of it in my introductory remarks, really, which is I do think we've got to get the balance right of top-down direction and being able to make local judgments and decisions on the basis of local circumstances, and particularly on dialogue with our local communities. So for me, it's really important that we retain some level of flexibility to make some local determination about what's really important in our own context. I think it's critical we don't lose the long-term plan. So, you know, when we did our long-term plan, I don't know about others, but we looked at our population, we looked at the services we have in place, we looked at quality, we looked at standards, and we said, you know, where do we need to really improve things for meeting the needs of our population, not only now, but in the future. So how the future is changing. So to go to Donna's point, for example, you know, we're very focused on developing what we call integrated care partnerships, but are really the kind of community partnerships that you're talking about, Donna. And I would be really upset if we were to lose some of that focus, because that's about how we meet the needs of our population, not only now, but for the future as well. So I think there has to be some local flexibility to enable balance. There are challenges, there are practical challenges around infection prevention and control. There are practical challenges around the workforce, who, as you said, this is a marathon for the workforce, and many of them have come through one peak, and now, you know, we can see maybe the start of another, and we're going to have to address that. But for me, it's about having that real flexibility to identify and act on local priorities in order that we can meet the needs of local populations.
Thank you. And Fazana, what do you make of the sort of push to the phase 3 letter and the long-term plan while managing the immediate challenges?
Well, I think I was really struck by Donna's fantastic point of we need to reset, don't we? We need to reset, and looking at the report, you know, the majority of our leaders who responded to the Confed survey were looking at, you know, we need a bit of honesty and realism, and I think how do we realistically achieve the ask of the phase 3 letter? So, for example, just a small issue in primary care, you know, we know that cancers haven't presented, you know, in the last six months, and we know that the rate of cancer diagnosis is worryingly going down. We know that cytology, so for women, the cervical cancer screening, apart from the high risk people, that it was put on hold. Now that's come back again. Common sense suggests, how do you suddenly make up 6 months backlog work with the same workforce? How does that work, particularly when you want to social distance your patients and work within those confines of infection control? So I think we do need some honesty and realism. I think I'm really pleased that, as Julia says, this is about place level, and this is why I'm always excited to talk about primary care networks, and I have one of the privileges of having a board at Confed where I've got not just 14 but a reference group of more than 100 CD, so I got a real wealth of experience of what's going on in the country, and there's some really great work happening. So when we are expecting our acute care to, you know, have 80% of their outpatients up and running, I think in the past, perhaps, Victor, it would have been very much them and us, so they need to do this. Now it's about how do we work together. That's not happening, you know, locally. It's not happening in a lot of places. How do we work together? How do we embrace our technology, our digital things? Do all our patients need to go to those outpatients appointments? And as Julia says, you know, prevention is better than cure. My job as a GP is to make sure I keep my patients healthy. Once you're going to acute care, I think the horse might have bolted a little bit. So how do we manage to think about using our communities, helping our communities really co-design that, so that we can have at least some of the asks of the phase 3 letter, which is not easy to achieve.
Paul, it's a challenge, isn't it? The phase 3 letter and the inequalities that you mentioned so eloquently in your initial contribution. How do the two come together in your view, and how are you tackling those challenges?
I think in a way, the letter makes some important comments about health inequalities, but the things that are made to matter are the ones where there have been very clear targets set, and there hasn't been that same laser-like clarity when it comes to health inequality. So I think what has to be done, and what is being done certainly in my system, is a recognition that the approach to health inequalities has to be place-based. We are working with our local government colleagues. Indeed, it's local government within our ICS partnership that are leading across the 2 counties our shared endeavour. But I think it also requires real engagement and a different way of thinking by those who are responsible for managing huge estates and huge budgets within our larger NHS providers, because their reach is far greater than I think many currently understand it, in terms of the supply chain impacts, the employment, and where their staff actually live, because they're living in some of the places that are facing the greatest adversity. And that needs to be built into the way in which we gain better insight and reach to those communities and populations, some of those that Julia was talking about. I just have really one reflection on the letter itself. The letter is an artifact of the time it was actually drafted. And it was drafted at a point when the pointers were going in a rather different direction to the way they are now. We have, I think, a different view about what the likelihood of the second wave is as it moves south in the country. And the question I have to ask is, does it make sense to plan for something that's unlikely, which is that we will be in a position over the next 6 months to restore services in the way that were envisaged in the letter? Or does it make more sense to plan to ensure that we protect capacity as best we can, but actually that we are also, again, pivoting into what looks like a very intense period within the second wave? And I think that will be a much more sensible use of our planning resources, rather than perhaps planning for unicorns.
Good answer. Thank you, Paul. Donna, I just wondered whether you had a reflection on that point of how we maintain what we've achieved, but deal with the phase 3 challenge.
Yeah, I think, well, certainly in Greater Manchester, we're looking to try to encourage more flexibility across acute providers within our STP. And because I've been honest, we haven't really. We've done loads on population health in GM, but we haven't really had that level of flexibility. So improving specialist care, for example, has been one thing that's got on my nerves. Is we've produced hundreds of business cases and not actually implemented them, because there's been this kind of organisational sovereignty issue. So we've got to move to more flexibility across acute providers within the place. Absolutely, definitely. And that's something I think NHS Confed gets in the report, and it's something that we need to be pushing as leaders all the time. I think the second issue is, as someone commented earlier on, funding. Julia, funding hasn't been an issue. The magic money tree has suddenly appeared again, and there it is, and NHS has been funded, but that hasn't been the same for local government colleagues. So social care, we cannot get through a second wave of this pandemic without well-resourced, well-prepared social care. And local government colleagues have been, they've been at the forefront as we have of the pandemic, but they haven't received the same amount of funding. Some of them are facing bankruptcy at the moment. So that's something that does need to be resolved.
That was a point well made. I've got a question from Elizabeth, which seconded. Elizabeth, she's keen to hear from the panel, actually, so am I, about how you're managing the workforce. She talks about vacancies and how local leaders can increase the number of people from their own communities that are filling the vacancies. But I think there's a bigger question, which is the sort of stress that many of the frontline and managers and leaders are under, and the sort of moral harm that's been done by the panic and by the pandemic. So I just wondered what practically your systems organisations are doing or thinking about doing that might address the vacancies issues if you have them, but more, and as importantly, the sort of the stress, just the sheer stress. We all clap for these people, but we have to do more than clap, don't we? So I'm just wondering what your thoughts are. Perhaps I might start I ended with Donna, but perhaps I might start with you on this occasion.
Yeah, thanks, Victor. We're doing loads, and not really me, but our chief exec and exec team are doing lots more reward and recognition for staff. We're doing lots of pulse surveys. We're allowing people to work from home where they can and supporting them to work from home, because that in itself can be really stressful. Working at home, you know, people think it's dead easy, but it's not. I think it's easier actually to be there and to be on the front line. So we're doing loads to support people, and we're really lucky that we've not got any kind of vacancies at the moment that we can't fill. We're really we're kind of breeding a talent pipeline in Bolton at the moment from our local community, trying to add social value by being a good anchor institution in the local community. And as the biggest employer, we've got a responsibility to try to recruit as many people as we can from our local economy.
Thank you. Paul, how is that issue being tackled in your system?
So I give an example from North Central London, where the Tavistock is based, and where we worked across the whole of the SDP. And very early on in the pandemic, we set up an online set of resources with regular pulse surveys of all staff across the NHS, very much about gauging how people were feeling, what were things that they were worrying about, and there were things around sleep hygiene, and concerns around the virus and what it meant at those early stages. So some very practical support and information was being generated as a response to that feedback, and that feedback was sent back into each of the organisations as well, so they could tailor their own responses. I think again, the fact that we have access to this technology has meant that it's possible to gather and brief and engage with far more staff than often we have traditionally done. And I think that has been a useful way of actually holding and containing some of the sort of sense of stress and worry and anxiety that you mentioned at the beginning, Victor. But I think there is still an awful lot more to do. I think the issue about vacancies, I would say that certainly in Hertfordshire and West Essex, we've seen against the operating plan we set at the beginning of this period, that we've actually got more people joining the workforce. We've been using bank and agency less. You know, that return to service, that sense of returning to duty by many former NHS employees has been very striking, and I think it's something we have to think about how we retain that goodwill and that sense of commitment that has clearly been to the fore during the first wave as we begin to anticipate a second.
Fazana, what's your view? How have you experienced this pandemic in terms of the staffing?
So I think for primary care, Victor, we know that we are very short of GPs and nurses nationally. We know that it was a problem, you know, pre-COVID, and I think as you know, Julia and Donna said, remote working gives a lot of flexibility, but is not without its stresses. A lot of people are working longer hours because of that, and there is that isolation. I think because primary care and the model of primary care is that there are a number of individual practices, and certainly primary care networks are helping that, but the support for staff is quite variable depending on you know, where you work, and I think there's a lot of work to be done. I know there's some great national offers from NHS England on coaching, and you know, there's lots on offer, but I think there's a lot more to be done. And of course we know that particularly for our primary care nurses, you know, not all of them would have the luxury of working remotely, because by definition a lot of their procedures are to be there face to face. How do we make sure that they feel safe? How do we make sure that they're not concerned about, you know, their own health? So a lot of work to be done. In terms of vacancies, again, I'm in an area in Newham where we've had the highest number of furloughed workers in the whole of London, and unfortunately we know a lot of them will be unemployed. There's some great work going on at Confed. Michael Wood is doing some great work around employment, and we need to remember, don't we, that health in itself is just a small part of somebody's well-being. We need to think about that, how can we recruit from our local communities to fill those vacancies, and also make sure that they are supported. I think it remains a challenge at the moment, actually.
We do know that for every month someone's unemployed, their mental health measurably deteriorates, so it is a real challenge. Julia, how is your system dealing with the staffing challenge?
Yeah, well, again, I think the NHS has done a huge amount of work, and indeed our partners in social care have done a huge amount of work to care for frontline staff in terms of all the challenges that have already been mentioned. I suppose what I always reflect on is our staff are just people. They're people like any other people, and they experience all exactly the same challenges that we talk about in respect of patients. Some of the things for us particularly that have been a challenge, I'm speaking now as a CCG because colleagues have covered kind of more provider side, but you could be fooled into thinking that, you know, well, CCG staff are back office staff, it wouldn't have a similar impact. But my staff have really had lots of struggles, and the things that we've heard about, top of the list is that managing childcare whilst also trying to work remotely from home. And that has been hugely challenging. So helping people to be more flexible, etc., has been really important in that. We've heard a huge amount around social isolation, and it's interesting because I hear from my colleagues across the system who actually are now going into work. My team still aren't. My team are still sitting at home, and that can create, that can create more distancing in connection terms. And so we've had to think about how we engage. There's one really challenging time when we were having what we call an executive to executive with one of our providers, and they were all, that whole executive team was sitting in a room together, and we were all on Teams, and it really didn't work. So we've had to think about how we connect in a world that is largely face-to-face, where my team are still having to work remotely. And then thirdly, for us, of course, big challenge about the future for commissioning. And by the way, we might all have our views about commissioning. I have mine. I think that, if I was honest with you, I think STPs and ICSs are an absolute indictment on commissioners, because we should always have been doing that sort of what I say to my colleagues is the conducting of the orchestra, making sure that every part has what it needs to play its best tune, in service of the whole, which is of course about meeting population needs. So I think, whatever you think about commissioning, that existential threat that comes with, we're starting to talk about structures again. I mean, why the hell are we talking about structures? I'm sorry, when we're right in the middle of the hardest time we've ever focused on. What I loved about the pandemic was we were all in it together. When my staff were rocking up doing stuff, no one was going, oh, they're from the commissioner, it's not good enough. We were all doing everything we could to respond, and I think we need to continue doing that. Sorry, that's me getting off my soapbox now. Thank you.
No, it's a strong and welcome view. I think that's right. I want to ask a question about, people talk about the community and charities and voluntary sector, and it's kind of, it can feel a bit amorphous. So I'm wondering, I mean, I happen to be the chair of Social Enterprise UK, 30% of community services provided by social enterprises, but I'm interested in what you think is the role of social enterprises, charities, community groups, as we reshape, if we reset the NHS, which we've got to learn from, 50-odd thousand deaths, right? What role does that sector play for you, really? What does it mean? Because it can't just mean warm words. So I'm curious about what it actually means for you in your systems. Perhaps we might start with Paul, and then Donna, and then Fazana and Julia.
I think what I'm going to say is what it should mean and what sometimes it does mean. I'll start with what I think sometimes it does mean and where it needs to change. I think sometimes it's seen as a free good that is available without necessarily any forethought given to the infrastructure and the costs of actually opening the shop, as it were, in terms of the community and voluntary organisations. On the other hand, I think what it is and what we need to increasingly invest in is essential social scaffolding in our communities. It is often the source of innovation, social and otherwise, and it has amazing reach into places that often statutory formal services struggle to make headway. So if we are serious about an agenda that is about making real an ambition around reducing health inequities, then we have to make sure that we are alongside and partnering with our community and voluntary sector. And I would put my hand up and say in Hertfordshire and West Essex, there's a great relationship between the council and its community and voluntary sector, and there's some great individual examples of services that are provided by the community and voluntary sector that are commissioned by the NHS. But we are not yet there when it comes to seeing them as an equal partner around our table, playing their part, not just in putting their cap out and asking for money, but actually there as a shaper and solution provider with the rest of us. And certainly that's my ambition as to what we need to see in our community and voluntary sector going forward. I think that's, in a sense, the challenge we have to embrace if we're going to have this wider ambition as we reset the NHS.
Donna.
Thanks, Victor. Yeah, I really agree with what Paul's just said. I think they should be part of the integrated care systems. They should be, you know, we talk about social prescription, and we have link workers working out of GP practices, as Fazana said. But if there is no social scaffolding to prescribe, it's like a travel agent with no holidays to sell. You know, we've really got to make sure that we've got that infrastructure there, that it's funded. We've seen a lot of, because councils have had the funding cut, they've had to cut grants to community and voluntary sector organisations, and that is, I think, really cutting our nose off to spite our face. You know, you hear some brilliant examples of projects that are there to support homeless people, to tackle mental health issues, and to support people through recovery and prevention. So, you know, very often it's not, we talk in the acute sector, don't we, about beds, and beds being the solution. We just need more beds. Well, if we were to do a business case around what is the more cost-effective way of intervention and supporting people, very often it might be, you know, a preventative mental health project for young people in schools or something like that. So they're absolutely essential, that they are the bedrock of our communities and the bedrock of our institutions and our places.
Fazana, what's happening for you in this area, social enterprises and community groups? How are they being managed?
So, Victor, I think we're only at the start, and as Paul said, this is more about where we'd like to be. We're certainly not there yet. But as far as primary care and general practice is concerned, and the primary care networks, again, have a real opportunity. In primary care, we should be absolute bedfellows with our voluntary care sectors, because actually so much of what we're doing is an overlap. And I think historically there has been a bit of a hierarchy of, as sort of Paul alluded to, and the charities are coming in as a last minute afterthought. Sometimes a bit like we bring the patient rep in as a last minute afterthought, and actually that needs to completely change. And I think, again, the primary care networks enable that. I work with a CD called Simone Yule in Dorset, which many people might know. They've done some fantastic work, starting with their link workers, but as Donna said, we need a destination. So they haven't just got link workers to send you to Mars. They've got you know, care navigators, health coaches, and really bringing voluntary sector into that. I think that is the key to keeping our communities healthy. And gosh, we have a lot to learn from them in primary care if we can just dump the hierarchy a bit as we reset.
Thank you, Fazana. Julia, but we've got to keep them funded, aren't we? We've got to keep but we can't talk in social enterprise if we're not including them in the strategy and the planning and funding them to do that. I just wondered what your thoughts are on that reality.
Yeah, thanks, Victor. I thought you might ask me that question. I mean, I want to say I really agree with everything everyone said, and I'm happy to say I don't think the third sector is any longer an afterthought in our system, but it's not yet where we absolutely need it to be. The knotty question of how we fund third sector organisations to do things on a systematic and more industrial scale, I think, is the challenge. So lots and lots of engagement of voluntary sectors, voluntary sector organisations, and of course the pandemic has really again accelerated the role of the voluntary sector, certainly in our system. So, for example, the voluntary sector, we already have within our STP, we have a whole programme of work which is led by the voluntary sector, by leaders in the voluntary sector, which is about how we embed the sector in our place-based partnerships, in ICP. So how do they become members of the board? Well, they already are members of the board, but how they're able to join up and align across the sector. So the challenge is, of course, the variation in the sector, and we're working out, and we are funding that. So we're funding charitable organisations to be, I mean, in old money, we used to call them the anchor organisations in each ICP. So there's an embedded, often it's a sort of community voluntary organisation that's already got a big reach and is enabling us to connect the two sectors. But just last week, Victor, I met with Turning Point, your successor in Turning Point, and you know, we were talking then about particularly for us in Bristol, the homeless is a huge population, a huge vulnerable population we have to address, and we have to think about how we actually procure properly commissioned services off the third sector. And we do some of that already, but again, how do we do that at a more industrial scale? So we're definitely grappling with the issue of how we resource the third sector. I'm delighted to say, of course, our community services provider is a social enterprise, and we built into their contract a requirement for 30% of the value of their contract to be expended with the third sector over the time of the contract. So we're doing some things, but you know, it's a big challenge, and it's not the only challenge we have for how we invest our resources. I talked earlier about the parent care partnership, what we're doing for complex children. Again, a massive role there for the third sector. So I don't think there's an easy answer, Victor, I'm afraid. I thought I'd love to be able to give you one. I don't think there's an easy answer, but I think the key will be shifting the focus of balance in the way I talked about in my opening statement, from always being concerned about the acute sector. And Donna, it was good to hear you say that, to thinking about how we meet the needs of our population now and in the future. And I think that's a different focus, or at least it's a rebalanced focus from where we are today.
To be said about that, you know, we have to manage the demand, otherwise we just an acute. It won't work. Thanks for mentioning Turning Point. I'm sure they'll be very pleased. They hope they're on the webinar. That's cool. So we're closing, but there's a couple of things I do want to ask you about. The one is about technology, and you all mentioned, I think, in your opening remarks, the fact that technology has been adopted pretty quickly. And I know, I declare my interest. I'm a digital vision person, so I've set up digital companies and all that. But I just wonder what your strategic thoughts are about how digital might be placed. Because there's a difference between, you know, everybody jumping on and then thinking forward, how do we use it wisely, and how do we deal with some of the issues that you've mentioned around access, equity in relation to technology, and how your systems are thinking about that moving forward. Now you're planning for it. Perhaps we might start with Fazana on this one.
So thank you, Victor, because primary care has, you know, the buzzword, we've gone digital. So I think there's a couple of issues, isn't there? One that I think needs a bit of a look at is that, you know, we sort of jumped on for need and did this very quickly. For me, digital is still just another way to provide the healthcare that we want to most effectively. So it's really important for me not to get stuck on the mode of delivery, to make sure that we don't forget what it is we're using the digital for. So I think there is something about training, because at the moment, you know, we've all gone in and done it in primary care. We probably do want to sort of evaluate that and look at whether you know, there's variation and safety and all of that. Then there's, I think, a whole piece of, you know, who are we excluding? I think, was it, sorry, Donna, Julia, one of these lovely ladies said earlier, what about that cohort of people who aren't able, for whatever reason, to use digital, but don't want to have face-to-face appointments either? What about those people? What are the alternatives we can offer? And then there's the real poverty. So a couple of things, just you know, very micro example we're doing at our practice is that anybody who doesn't have a computer can actually come into one of our, what we call a clean room, one of our clean rooms, and actually use that. And we've got our staff helping, you know, train people, because a lot of it is fear. So little things like that can help. But I think it's really important that we don't forget why we want to use the digital. It is to provide healthcare. The digital isn't the destination in itself, but some fantastic efficiencies. So we used to have a human doing people's blood pressure for no apparent reason. We just used to have a human do that. We just don't need to do that anymore. People can come in any time, 8 till 6:30 weekdays, and stick their arm in the blood pressure monitor, or they can do it at home. A lot of people have blood pressure monitors. So seeing that self-care element, because actually we're trusting our patients and our populations to do stuff rather than mummying them and daddying them, that's been a real benefit. And those advantages of working very easily with community care and acute care, being able to jump on meetings together and do some outpatient clinic appointments together. So not to lose the great efficiencies and advantages we've got, but to remember that it is just a tool to provide healthcare. Thank you.
Thank you. Donna, you know, you talk about the community and the engagement very, very eloquently. The digital stuff's here to stay. I'm just wondering what your thoughts about how you can use digital strategically to build place.
I think it's important that all public sector people work together on a digital inclusion strategy, so that it isn't just the NHS working in isolation. I think what you tend to see is different projects that are all trying to interplay with the same individuals and families that have come from different sources. So it's important that we work together through our integrated care systems. It's important that we remember when we did something in Wigan about 5 years ago, where we found we had one of the most digitally excluded communities in the whole of the UK. So a huge percentage of people did not have access to any kind of technology. So we went out there and we did a lot with our local libraries. So we saw libraries no longer as just a place where you get books, but we had them as digital hubs within local communities. And there's no reason why GP practice, you know, extended GP practice can't become a digital hub within a local community. We had lots of digital projects that came up that were came from the bottom up, that came from communities themselves who wanted to share tech, to invest in tech, and to think of how tech can improve the quality of life. So I think it's got to be you know, find ways of commissioning differently, using community expertise and the experts we have in our local neighbourhoods.
Digital part of your ICS strategy, and is it focused in a particular way to address inequity?
So definitely, for sure, but I think we have to ask ourselves what we mean by digital. I mean, there are three things that come to mind immediately for me. So we're doing a shed load to share data, and I'm delighted to say again, COVID has really helped us. We've now got social care absolutely embedded in our shared care record, but we're moving towards other local authority data sets, which are so rich in helping us understand local populations. So I think the whole piece about data sharing, how that helps us to better, you know, meet the needs of people. Second of all, we've all talked about virtual platforms, and you know, those have meant that many more people come together more regularly, you know, to give better leadership, to have better discussions. I think one of the areas I've found more difficult is bringing together community discussions virtually. I think that's been more challenging because it's more difficult to build relationships. I found that, you know, the thing I really struggle with is when I'm looking into your eyes, Donna, of course I'm not, am I, from your perspective? So that ability to make human connection, I think, is really challenging. But I suppose what I'm disappointed in the digital field, that I think I think certainly the NHS and to some degree social care as well has stalled more on is digital technology that enables independence at home. And I think that's where we really need to be focusing our time and energy. And there's so much now, so much more we could do in that innovative world. And I think some of that requires us to join up with industry and through LEPs, etc., to look at how we can fund and support innovation. But, you know, I once went on a trip to Denmark to have a look at what they're doing there. And really, we're light years away from really focusing on, as I say, digital as an enabler of independence. So that's really, I think, where we need to really ratchet up the focus.
Paul, if you can hear me, that is. Can you hear me, Paul? It's all gone quiet at Paul's end.
Yes, I'm sorry. I didn't hear you call me to say anything. Sorry, Victor. Just a couple of comments, if I may. I absolutely agree with all the points that have been made by colleagues on the panel. Particularly pick up on Julia's point, really, about what I would describe as taking an occupational health lens to a lot of the challenges we're talking about here. In other words, focusing on what matters to people, and in that sense, the repurposing of everyday technologies to facilitate people maintaining their independence in their communities is an incredibly important part. And there are some great examples that have existed prior to the pandemic, but certainly have been progressing through social services and through particularly housing associations with their alarm call businesses and so on. They've definitely been doing more, and there's more to learn, and opportunity perhaps for that to be better integrated into the NHS social care dynamic as well. Two comments really. One, I think strategically the important thing is not to be obsessed by the kit. This is not a procurement exercise simply about buying things. It's actually fundamentally about transforming and redesigning services. And I think very often we get distracted into the buying of the stuff rather than the outcomes we're trying to achieve. So I think I would sort of echo those points. I think there are some issues around how we've by necessity moved to so much more remote delivery of healthcare and social care to some degree as well, around consent from our population for these changes. I think we will have more to do on that over the coming months and into next year, in terms of if we are to lock these changes in, we have to be assured that the public actually have bought into them as well, and not just acquiesce during this period of crisis. And that's where I think the final point I would make is that this is actually another route into really amplifying the importance of shared decision making. And the downside risk of remote and digital models of working is that the power imbalance that exists anyway can be extenuated and made greater. So I think we have to be keeping those things in our minds as we work our way through the next few phases of coming through the pandemic.
Thank you. Right, we've got one. I'm going to give you each a minute just to give one piece of advice. There's a lot of people listening and a lot of people on this webinar, and you are great leaders in the health and care sector. And I just wonder, you know, if you're sitting in, you can do this on video, you know, sitting in front of somebody who is facing the same challenges that you're facing, what's the one piece of advice you'd give them to get through the next year, the next period as COVID strikes again? What would it be? Perhaps we might start with you, Fazana.
So I would say keep going. Life is uncertain. As Julia said earlier, we are all patients and we are all humans. Keep going. Don't be afraid if it doesn't go quite to plan, because you'll still be at a different destination to where you are now, and keep working together. Let's forget our titles and let's forget our organisations. Let's work together to look after our communities.
Excellent. Donna?
Thanks, Victor. I think it would be to listen harder than you did before the pandemic. I think there's a tendency, isn't there, and we call it gold command, and it can become quite kind of top-down, process-driven commandment type thing. Like Neil said at the beginning, almost like it is a religion. and that isn't the NHS and social care or communities working together. It's got to be about listening to frontline staff harder and listening to our communities, because that's where the answers lie.
Excellent. Paul?
Again, I would echo the last 2 points. I think it is about that sort of, if you like, humility, being prepared to acknowledge what you don't know and be willing to ask others. And in a sense, we're all navigating new times, strange times, and in a sense, acknowledging one's own vulnerability, and in some cases, not knowing, and being open to listening to others and their thoughts about how we proceed is, I think, an absolutely key part of effective leadership at the moment.
I think that's absolutely correct. Thank you. Julia?
Yeah, so mine would be see people as people. We're all people, whether we're talking about the people we serve, whether we're talking about the people who work with and for us, or whether we're talking about ourselves. So take care of ourselves. We're in it together, and it's if there's one thing that has been the massive joy of this last period, it has been that sense of being in it together. And finally, I'd say take up your power. So that thought I have about the fact that that irony of people saying that they felt more empowered when those of us sitting where we are know the reality of that, but the reality is people felt empowered and they got on and did things. So my advice would be for everyone to turn your face to what can be done, what needs doing, in service of what we're trying to do together. And remember, we're all people, so take care of yourself too.
That's wonderful. That's great. I've got some questions for our panelists, not panelists, for our listeners and viewers to ask to close our session. We started with you, so we'll close with you. And the questions are as follows. As we move towards the next stage of this crisis, to what extent do you feel that the government have learned and held on to lessons from the last 6 months? I bet the panelists wish I'd have asked them that question. Actually, it's not a bad question, is it? Do you want to have a little go, little quick? Do you think the government's learned anything the last 6 months? You can be brief. I'll let you have a go. Who wants to go first? Let's go with you, Donna, because you've got the biggest smile. Go on.
I thought you were going to say I've got the biggest mouth then. I have as well, actually. But yeah, I think it's going back to pinching Paul's point, but have a strategy. Don't have disconnected ministers making announcements without the detail being worked up. Have a clear strategy. Look and learn about what is already out there. Public Health have been doing contact tracing and testing for donkey's years. So building up from that, look at the expertise we've got in our NHS labs, use that, dividing it up into the different pillars. Where did that come from? Let's build on what we've got and build that up and resource it properly.
Paul, briefly.
Enable, don't disable. Work for a distributed leadership and listen to the front line.
I love that. Enable, don't disable. Like that. Fazana.
Again, just echoing, listen to the front line. We will respect you just as much if you listen to the front line. It doesn't have to be a top-down command. We'll still respect you, but listen to what's already happening, build on what we've got.
Julia.
All of the above, and have the courage to do the right thing.
Yeah. Not just something. Yeah. So,
well, not just
yes. And the other questions are, as we move towards the next stage of this crisis, to what extent do you feel that NHS EI has learned and held on to lessons from the last 6 months? I won't ask you that question because you don't have time to answer it, but it's always the case that NHS EI, like everyone else, has to either lead, follow, or get out of the way, I guess. And then the last question is, as we move towards the next stage of this crisis, to what extent do you feel that your organisation, sector, has learned and held on to lessons from the last 6 months? And that's a key question, because that death and suffering cannot be for nothing. It's been fantastic listening to all of you, Dr. Fazana Hussain, Paul Burstow, Donna Hall, and Julia Ross. I think your contributions have been outstanding, actually, really, really good. And that's the evidence for that is that we've had very few people drop out and more people drop in, which is which is telling you something. I've really enjoyed this session, and I hope we get to. Well, I'm going to be speaking to each one of you actually over the next few weeks and months. I'll look forward to doing that. I think that's where we close, but I'm never sure with these things whether somebody closes for us or I have to close the session.
Yes,
so Victor,
thank you, Victor, and thank you to the rest of today's panel. Thank you everyone for attending today's webinar, NHS Reset, the Future of the Health and the Care System. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 48 hours with a link to view a recording of today's webinar. On behalf of NHS Confederation and our presenters, thank you for joining us today and enjoy the rest of your day. Thank you, everyone.
Thank you, everybody.